So I'm Senior Hacker, Joanny, dear colleagues, dear fellows, good evening. Well, today we have the PANWEST Powers event. As we know, pancreatic treatment has received more and more attention at home and abroad. Well, we have done a lot of preparation so that colleagues home and abroad we can join our effort to tackle the difficulty in treating pancreas so that we can have some highlights for the future forward. Well, today we have this experiment. We are supported by Shenzhen University and started the PANWEST Powers activity. Hopefully, by doing so, we can build friendship with the international community and talk more about pancreas treatment. We have the first part, that is speeches. We will have Professor Shun Hao from the Department of Hepatobiliary Surgery Department of Xi'an University First Affiliated Hospital. Thank you, Professor Wang, dear colleagues, dear professors, experts. Well, it's an evening in China. Well, I don't know which time zone are our foreigners, but first of all, thank you for the invitation, Mr. Wang. I was having this responsibility to make speeches, but I don't know what to say, but I will only show you the development history of our Department of Hepatobiliary Surgery. Well, from 1986, we started the department building with 4 generations of effort. We started from 36 beds to 200 beds. We have a growing team. In the early generation, the first generation of the hepatobiliary practitioners, when we started the standalone department, we're now passing down to our generation. We are the fourth. Now we are having a leap for development, having more and more beds. Mr. Liu, other professors, they paved the way. Now moving to our generation, fourth generation, have the Professor Wu Zheng as the leader. Well, what he contributed is having a specialized development. For the hepatobiliary surgery department establishment, well, under the first generation, Professor Wang made a lot of contribution. Last year, in 2024, we completed over 300 surgery related with the pancreas. More than is close to 400 pancreatic surgeries, and also we have 26 clinical trials. 3 of the trials are the multi-center collaboration trial. We will also have a phase 3 trial very soon. We have not only from the clinical trial and the research and development, we have made a lot of progress, and for the endoscopy plus pancreas treatment, CT, ultrasound combination, etc., also has achieved a lot of progress. We are very proud. We are sitting on top of the progress of the 3 previous generations. I also have a great prospect for the 5th generation, so that we can have a much better, brighter future for our development. Thank you, Professor Shun Hao. I would like to introduce Professor Shun Hao a little bit more. Professor Shun is a very famous professor in the endoscopic treated pancreas. So next we will have another speaker, Mr. Professor Ma Qingyong, who is also a very influential figure in China in terms of the pancreas area. Thank you, Professor Ma. Dear colleagues, professors, experts, home and abroad, good evening. Just as Professor Shen mentioned, you probably are in the morning time zone. I will now also say good morning and good evening on behalf of the Cancer Center for Pancreatic Cancer Center of the Xi'an University. I would like to welcome our experts and colleagues to participate in our virtual online meeting. We know that pancreatic cancer is a refractory disease, and treatment options are very limited. We have just surgery to be therapeutic, and also the mortality rate is very high for the pancreatic cancer. Now, having this PANWEST pulse activity, I think it's quite necessary. Also, I believe during this event, we will have very big significant changes, and it will be a milestone for our exchange and communication. We know there was a circuit starting from Xi'an, it's in the Westward. Also, we have the government event, and also now we have this PANWEST House event. So we hope to seize this opportunity to take this platform to collaborate with domestic and international experts on pancreas to share our successful experience and share our lessons through individual pieces, clinical techniques, clinical practices, research, business engineering studies, etc. We can learn from each other. We can ensure mutual growth so that we can contribute our efforts to safeguard people's health and tackle this pancreatic tumors and disease. Thank you again for taking this opportunity, for joining us. I hope on this platform we can share our feelings and secrets so that we will contribute our power to the development of this pancreatic disease. So we'd like to wish this conference a complete success. Thank you. Thank you, Professor Ma. Like Professor Ma mentioned, Xi'an is the starting point of the Silk Road and also an important node city on the Belt and Road. In this significant place, we are having this international conference. I believe it has its implications. So I want to pay leverage the long history and geographic position of Xi'an to better build up a platform for pancreas change and collaboration. So let's move on to the first item on the agenda, that is about exploring global frontier in trends. So we will be joined by two top-notch experts from abroad for presentations, and also we'll discuss some popular topics. I hope we can have relevant insights and takeaways, and we can engage with discussion. So the floor goes to Professor Rick Levine from the Affiliates Hospital at Xi'an University, and also he is a doctor from the Hamburg University of Germany, Doctor of Surgery. Thank you, moderator. Thank you, Professor Wang. Good evening to those professors in China and afternoon to the international professors. I will do a brief introduction to the international friends and professors joining us today. Our keynote speaker, Professor Theo Hackett from Hamburg University. and he is director of the PANWEST Institute, and he will talk about the pancreatic surgery, history, and surgical skills. Floor is yours.
Thank you very much for this very kind introduction and also for the invitation to this first event that you have started here from Xi'an. Good evening to my friends in Xi'an and in China, and of course in Japan, in Mumbai. I've seen all over the world, so good morning to Brazil. So I just try to share my screen now, and then we can start this lecture. So if you can see everything. The topic is development of pancreatic surgery and surgical skills. So this is kind of two points that I want to address. And of course, when you think about the development of pancreatic surgery, there are some historical milestones, and then the second part will be about the surgical skills and the techniques that I think they are important today to really give a good operation to the patients. The historical milestones some 100 years ago, people used to say you should not mess with the pancreas because the pancreas is only dangerous and will only kill the patient. You can do everything else, but do not touch the pancreas. Of course, we know that this is not the case today anymore. So some 100 years ago, there were the first really pancreatic surgeries. One was Walter Hausch, who practiced in Berlin, in Germany, in 1909. He did the first radical dissection of an ampullary cancer, which was, of course, a pancreatic duodenectomy by that time. He unfortunately did not become very famous for this operation, but still he was one of the pioneers doing this operation. And then, of course, the next one that was really important was Alan Wickel, who practiced in New York City, and he was the one, all of you know his name, who did the operation many times in his life and made it very famous in the 1930s. Interesting thing is that he did not do the operation on one day, he did the operation on 2 days. On the first day, he only created a connection between the gallbladder and the stomach to make a bile drainage for the end of the operation. And after that, he stopped the operation. And on the next day, he then completed the dissection by doing the Whipple procedure. And by that time, he only closed the pancreas. He did not do a pancreatic anastomosis because the techniques were just not able to do this by 1935. However, just to show you how developments happen, it's quite interesting when Whipple did the first operation on one day. This was some 5 or 6 years later in 1940. We had some visitors from Europe, some surgeons from Europe who were quite famous, and they wanted to see Whipple, who was already famous for his operation there. And when they looked over his shoulder, he did not dare to stop the operation, but then he just completed the operation in one step, and that was the first time Whipple was done in 1 day. So I think it's quite interesting that sometimes you need some kick from outside to get some progress when you don't dare to do something, and then suddenly you try it and you see it works finally. Other people did this operation finally as well, but you see, some 50, 60 years ago, this was a dangerous operation. Mortality was between 32 and 82% by these years. So this tells you it was not a standard, it was not what we are expecting today. And this finally happened in the United States in the 1980s. This guy said Congress should make a law doing a Whipple operation is an illegal thing and you should be punished for this. And you just keep in mind, this was in the 1970s and 1980s, but of course, some other pioneers were, of course, doing this operation. They were not realistic as other colleagues, and they did some modifications of the Whipple operation. I think one of the most important was the preservation of the pylorus. They just said we do not resect the stomach, we can keep the pylorus, and the first experience published in 1981 by Charles of Delaware, who of course also very famous not only Whipple. They did 8 patients, and what they could show is that they had a very good functional outcome for the patients, which means they had very little problem with weight loss, with vomiting, with other things like diarrhea and increased bowel movements, because they just kept the physiology of the stomach intact and they did not do a more radical dissection of the stomach. Now, this was just a brief introduction to the, I think, most important people who were the pioneers for the big pancreatic surgery today. Now, what is important in surgical skills? I think the most important thing when you do a surgical operation for cancer, you need to check if you have any arterial infiltration. As you see from our CT scans today, this is an arterial infiltration, but sometimes it is not as clear as in this patient, and then you should do something like the artery first approach. I think this is one of the important steps in the beginning of the operation, and this is just shown here. You start your section, for example, from the left side, and then you can expose the SMA and everything, and you can check if there's an arterial problem or not, because an arterial resection is certainly something that you do not do every day. You can do this from different sides. You can approach this from the left side, you can approach this from below, you can approach this from the back. This is up to you, what you prefer. You can also approach the artery from the anterior process. I always like to do it from the posterior approach, which means from the left side of the triceps ligament as the first step of the operation. So I think this is the first important surgical skill and the important surgical technique in a booking procedure that you should always use in my estimation. Does this also have benefit for the patient? Everybody thought, this must have benefit. And then there was this first Spanish trial, this was a randomized controlled trial, and the endpoint was the radicality of the resection when you use the artery first approach, and also the mobility and mortality. And when you look at these results, they are quite disappointing because the arterial resection rate is exactly the same if you do artery first or if you do the standard approach. And also everything else is exactly the same. So some 5 or 6 years ago, people would say, maybe it's not necessary, you could not do this. But of course, this was just one first RCT that was published on this topic. Of course, there are some more progresses to be made. And Professor Immer's, also online I've seen, he was one of the first people to describe this dissection radicality, turning this a 1 to 3 dissection, depending on the lymphatic clearance of the tissue, and this was already 10 years ago. You see, level 1, you can stay on this side of the SMD, you can take away everything up to here. Level 2, you can go on the left side of the SMD, you can take away much more radical. And level 3, which is some kind of really radical operation on the right side of the SMA, this is what you should do when you really want to achieve an absolute radical resection. This is again shown here, and when you do this, I think this is very important. Level 1 is only something you should do in benign disease of the pancreas, maybe low-grade malignancy. Level 2, you should do it things that are away from the vessels, pancreatic cancer, for example, but not for a standard pancreatic cancer. For invasive pancreatic cancer, you should always try to do a level 3 dissection, because then you only have the chance of radical clearance here. This is shown again here. Level 1, you just leave some tissue around this, only for benign diseases. And then, of course, level 2, out to the left side, and level 3, when you have really good clearance in here. Is this a dangerous operation? Of course, you always have to think about this. It is not dangerous when you know your anatomy before you have learned your surgical skills. And this is just a nice example from the same application, how your vascular dissection has to be respecting arterial branches and also the venous branches, and how many patients involve which anatomic variation. And you should always be aware of this before you start this type of resection. Otherwise, this might be something bleeding and you might not be very happy with this technique then. When you do it, you can actually do it quicker than conventional resection. You have less blood loss because you have very good vessel control, and you have not really more complications. Actually, you have some less complications when you do this very clean dissection here. So I think this is an important topic, and if you don't do this, you can of course do artery first, but then artery first does not end in a more radical resection. We have published some quite similar things. We have published the triangle operations 8 years ago because we already focused on surgical technique after neoadjuvant treatment, and we should do the clearance there. And you see this is the so-called triangle. You can clear the SMA, you can clear the coelom axis on either side, or you maybe mostly need to resect, but then you have also achieved the good clearance. If you don't do this, you will have some images like this in your patients. 3 months post-operative, you see around the vessels some unspecific tissue. 6 months around the vessels, maybe even more unspecific tissue. 9 months after the resection, you have clear local recurrence or local persistent sacral tumor because you have not cleaned the triangle and you have not operated gently enough. dissection operation. It takes more time in our hands. We have a little bit more blood loss in the triangle operation, but still this is something that comes with benefits for the patient. And you see your mortality and the number of complications is exactly the same as well for liver, as well for tracheotomy. The only thing that the patients really might experience is some diarrhea that you have to keep with some medication, but usually you can resolve this within 3 to 4 weeks after these very good operations. So we consider this as a safe operation, and we have to check even more for the long-term oncological effects of this operation. Of course, this has been done, and now there are some nice studies from China that I want to show you. This is a triangle operation versus a non-triangle operation, 52 versus 55 patients. What is the outcome here? When you look, the extent of radicality is the same as I showed you in our early experiences that we see here. You have, of course, today very good reconstructions, as I showed you. The vascular anatomy is extremely important for this operation, and we need to check this before, and then we end up with this clean target dissection. What you see is all of these things of the baseline parameters of these patients are more or less equal, but you harvest more lymph nodes with the triangle clearance, 20 versus 14, so there is some more radical advantage, and you can lower the recurrence of your patients. You see in the triangle operation 50-50, yes, no recurrence. In the standard operation, you have 80 recurrence percent and 20 non-recurrence percent. So there is a clear difference in your clearance and in your oncological outcome in terms of recurrence. And then, of course, regarding other variables, what is important for the survival of the patients, do the triangle operation, then you have an independent prognostic factor also for your recurrence and your oncological prognosis. What is the pattern of recurrence when you do not do a triangle? This is shown here. You have much more local recurrences than you have when you do the triangle operation. But of course, these patients also get their recurrences in distant positions. So this just shows you radical surgery is the one part, but this, of course, is the other part of the adjuvant chemotherapy that you need to be afterwards. And then you can also improve the overall survival when you do this and when you add chemotherapy to these patients. That's what I want to show you here on the last slide of this study. E4 is the triangle clearance plus adjuvant chemotherapy at least for 6 months, and then you have controlled local cancer and you have controlled distant cancer, and you have the best chances for your patients and significantly much better than if you do not do the triangle and not complete your adjuvant chemotherapy. Another study from China I'm showing you here, 150 patients, how much should we dissect on the left side of the SMA when we do this? Does extended lymphadenectomy on the left side give you more than on the right side? So group A, complete dissection, 180 SMA. Group B, complete dissection plus triangle. Group C, complete dissection 360 plus triangle. Is this an additional advantage for the patients or not? When you look here, you have, of course, an advantage when you do the complete dissection on 180 degrees, including the triangle. Then not including the triangle, you have more recurrences in these groups, but you have no further advantage when you extend it on the left side in 360 degrees. So probably this is not necessary and is not improving your prognosis. Only doing the right side, including the triangle, is the statistically significant prognostic factor here, and not do much more, because this will only increase your rate of recurrences and not increase your rate of recurrences, and will cause some more complications like diarrhea and things like fistulas that the patient might experience in the follow-up of the operation. Then, which lymph nodes are important? Another very nice Chinese study published last year. Medical techniques and the pathological features, especially of the lymph nodes, focused on number 9 and number 14 of the Japanese classification. And you see quite a large collective where this was examined here. And this is the types of dissection, either along the hepatic artery, shown here, or along the SMA, or including both of this, which is the group 3. When we see the patient features, standard dissection compared to the extended dissection, the basic parameters regarding lymph node ratio, soft tissue invasion, and all of these things is exactly the same. So there is no oncological baseline differences between these and to take it away, you always have to treat the diarrhea afterwards. What is the outcome in terms of the lymph node? I think this is quite interesting. Lymph node number 9, which is the beginning, you see, does not make a very big difference in disease-free and overall survival, but the lymph nodes number 14, around the aorta and the villi, they do make a difference, and if you clear them and they are then taken out, you have a much better disease-free and also overall survival. So there is a difference between the positions of the lymph nodes, but the most important part of this work is that you have taken this away, and then you can improve your outcome. And this again tells you theoretically take away the soft tissue, including all of the lymph nodes. Now, what is the current developments? We have operated for 150 years open, we have operated for 30 years laparoscopically, and we have operated for the last 10 years robotically. You see, there is a straight and fast development going on. The last 40 years have really made a big difference also in pancreatic surgery, here especially, of course, the last 10 years in the robot. Can we do a trial robotically? Yes, we can do this. We started this some 4 years ago with a group from Baltimore, the medical robotic technique. And you see also with the robot, you approach PSA, because you need to have some robotic experience before you dare to do this. You can remove all the low axis, all the lymph nodes, all the triangle tissue between the SMA and the celiac axis, and in the end, you have the same situation as you have in an open operation. So the robot does not limit your radicality. However, I said you have to be educated and you have to have experience, and especially the robot offers you great chances for this education and experience, and you can train with the robot much better than you can train with open surgery. For example, in the reconstruction, IoT models, everybody in the meantime uses this. What are the effects of training and experience? This is one of the earlier works regarding this question. What you see is if you have fellows who are not very experienced, but the consultants, only 5 attempts for the reconstruction in the stomach on the diaphragm or the pancreas and the soft tissue models improve your performance significantly, you make less errors, and your overall performance increases. Of course, you are not as perfect as some experienced consultants are, you need much more experience for that, but only 5 attempts can improve your performance significantly. We have tried to adopt this. We now have adopted this in Hamburg not regularly for our trainees. You see these are some examples where we have built these models ourselves. You can do this like open surgery, or you can also do it in the robot. And then, of course, we need some preparation for this. We do it from 3-dimensional CT scan. Then we put this in the 3D printer, and then we can print the pancreas, we can print all the vessels, and we can then give it to our trainees to practice, especially the anesthesiosis, but also the resection techniques in such a complete sequence that we can in the meantime print. We have compared this to the conversion biotissue, and we have tried out all of the silicone that we could get, and we see the haptic feedback for the soft pancreas, the haptic feedback for the hard pancreas is very good, depending on which type of silicone you use for this mixture for the 3D printer. And then, of course, you can also do the restitution yourself. And the haptic realism that we do for the training, we have also done this, can be improved compared to conversion, but this is the conversion beforehand. When you do it yourself, you have a little experience with these things that you put this together. And this is what we present at the moment every week in my hospital. All our trainees are sitting there, they have these models, they train the bowel anastomosis, they train the pancreas anastomosis, they train the portal vein anastomosis just using these things. And of course, they begin with open surgery, then they proceed to the robotic procedures, training this in the same way on the robot in the OR. They can do this every Saturday or Sunday if they want to. And I think this is a big opportunity where we are today, using the robot and improving our surgical techniques and surgical skills with the robot. I hope that I could give you a little overview of the developments in this area and also the developments and surgical skills that are required at the moment. And of course, I'm looking forward to any questions or discussions. Thank you very much.
Thank you for Professor Hart's great lectures. And then I want to introduce professors to my and then first of all, I want to introduce Professor Javan Grant.
Can you hear me?
Yeah. So you can say hi to Professor Francis. How it goes?
Yes, it's my great pleasure to stay hello to everyone, my friends, my great surgeons from all over the world. We are all united for the love of this surgery, which is pancreas surgery. I'm sorry I'm not traveling towards Germany, where we're gonna have the European Pancreatic Club meeting. I hope that this friendship will also lead to have more famous participants also to this annual meeting that we do in Europe every year. So once again, thank you very much for having me, and I cannot wait to see you again, hopefully in China. Whenever I come, I learn always a lot from you, and I feel it's an amazing way to increase our networking and also research capability. Thank you so much.
Thank you, Professor. And then I want to introduce another professor from Japan, Professor Yosu Ano.
Yes, thank you for inviting me for this great forum. I'm yesterday from Council State of Hospital, and I really congratulate your project to have on this so meaningful and so international and so scientific public forum. I already enjoy the great lecture of Professor Chilo Akari, my very member, mentor, and I again thank you, Chilo, for echoing my advice. I always admire your continuing achievement about the medicalization of public cancers. And today I'm not so enjoying, and I will continue to collaborate with our Chinese public sector friends. Thank you.
And every Monday we will invite you for discussion on some topics from Professor Hackett and Professor James Tobin.
Yeah.
Thank you. Yeah. And then I want to introduce next one is Professor
Hello everyone, my name is Faisal. I'm from Mongolia. I'm Gene surgeon. Thank you very much, all professors and all participants this meeting. Thank you.
Thank you. Thank you, Professor. And the next one is Professor Christine Patrick.
Yes, yeah, are you listening? It's okay, yeah. Thank you so much for inviting me for this. It's a great pleasure to be with all of you in this very good discussion. I'd like to collaborate in everything that I can do here from Brazil. I'm an HPV surgeon and liver transplant surgeon as well. So it's very nice to be part of this. Thank you so much.
Thank you. And next one is Professor Arabi Albert. And he's here. Hello, Professor.
Hi. Hi, hello. Thank you for being there with you. I'm very grateful for that. I'm from Sudan, also HPV and liver transplant surgeon. And because of the war now, I moved to work with Professor Lee living here. I enjoy the talk of trying the technique and I enjoy the rest. Thank you.
Thank you, Professor. And then next one is Professor Elvis Isaiah from Belarus.
Hello. Thank you very much for the invitation on this conference. My name is PANWEST. I'm young journalist from Belarus. A very nice conference. Thank you very much.
Thank you. And the last one, I want to introduce my friend. It's Nia from India. Where's Nia?
And I think you have taken a lot of effort to get the translation done, so thank you so much for the time and focusing academic exit to action and looking forward to the entire countries.
Next program.
Well, I think the summary of the call, what I told you is we have to improve our surgical skills, and we also have to do this with the warm-up, which of course is at the moment the big topic in Europe. I know that you are in China probably ahead of Europe because you have these incredible numbers and you're doing these robotic surgeries with a caseload that is unrealistic for any European country. I think Giovanni can confirm this for Italy or for Germany. This is simply not possible, probably also not for Brazil, I think. But I think countries like India and China, they can have these caseloads, and this is what I wanted to tell you, that we have to improve there and that we have to train our people for these techniques just to get the best outcomes.
Okay, then Professor Giovanni, Professor Arnold, and our professors, and there's a lot of questions and comments, and they can start those topics.
Yes.
Maybe we can continue.
Yes, I can only echo what Tilo has said. And also for our precious training is the most important learning issue that we have right now. And the robotic explosion is challenging us now with even more issues. But I also see an opportunity here because unlike the open approach, we know that there are many ways to be trained since the early stage, even for extremely young training. And there are many even learning methods that are now used. Some of them are European, others are international, under the auspices of other social society. So I think that's definitely the direction that we should follow, and thanks also to numbers that Tilo was mentioning regarding China and other big Asian partner. This probably could be even a positive factor, as of course we live in smaller countries dealing with relatively, so to say, lower numbers. So
You call me? You call me. I'm not. I don't. Yeah, please tell me. Yep. I love it. It's good.
Oh, sorry.
It's easier for you to call me Yoski. Fantastic.
Yes, I'm next time I'm professor.
I will make some comments and conclusion for the next speaker. Thank you.
can hear you, but there seem some technical problems with the other participants, I think. Yes, we have some more data on this, and the survival is quite comparable to the Chinese study. If you have the triangle operation plus the adjuvant chemotherapy, you really have an advantage out of this because you have the same effect as I reported in the study. You have less local recurrences, but also you need to control the distant ones. Yeah, but then this is an advantage, and at the moment we are just participating in a multi-center German randomized trial for the triangle, where we really randomize the triangle versus no triangle, but this is still ongoing and completed, so not finished.
So here we have
Professor, I have just one question that would you have a comment on removing the triangle tissue en bloc with the main specimen versus getting it out differently? Do you think it's going to be any different?
No, actually I don't think so, because sometimes it might be easier to do the major resection first and then clean the arteries, but of course if possible you should do it in one piece. But what is interesting, you should then separate it for the pathologist, just to see what is the triangle tissue, is there any lymph nodes in it, is there any more tumor spreading compared to the conventional tissue. But if possible, remove it in one. If it is too difficult, I mean sometimes you have with these patients where it's really difficult, as long as you have the little specimen still inside, then of course you can do it in the second step after you have removed the pancreatic head.
Thank you.
Professor Christian. I see we have questions.
Professor Carter, thank you so much for your amazing talk. Thank you so much. I have two questions for you, Professor. What are the chemoclinical radiological criteria your team used to indicate the need to have chemotherapy for borderline resectable or locally advanced pancreatic tumors, and which protocol is most commonly used for the institution? And the second is about training. What are the key technical skill milestones you track during the learning curve for robotic pancreatic surgery, and how do you tailor training accordingly?
Yes, these are two very important questions, I think. The first thing is when we choose neoadjuvant therapy, we do it always when there is an arterial content. We do chemotherapy first and then go for exploration and potentially resection. If we have only a venous contact, not in every patient. If you have a chance for technical reconstruction of the vein, we would not do neoadjuvant, but for the arteries always. And if we do neoadjuvant in our institution, and I think mostly in Germany, it's only FOLFIRINOX chemotherapy. We use no radiation. This is really not common in Europe. Most centers, some centers do, but we just do chemotherapy. And for the training, I think the most important thing for the training skills when you want to go for pancreatic surgery is the reconstruction techniques. I mean, the most important part is the pancreatic anastomosis. The resection you can train to some extent, but of course, there you have to have some, I think, open surgical experience first, that you know your anatomy, you know how to do the little procedure, and then you proceed with the robot, and the anatomy is not uncommon for you. But the reconstruction, of course, is completely uncommon. That's why I think this is the most important step for the younger people to do this first in the simulation and with the biotissues.
Thank you.
Thank you.
A question for you? Subject. We are doing the triangle operation where you differentiate like different diagnoses. Like for some small tumors, like only for the duodenum, to also do triangle operation only for pancreatic cancer, like we may have duodenal to also do triangle. Also, you mentioned that it's easier to do this triangle operation with robotics because they have different perspective, different angle, and now seems like everyone is doing a robotic assisted triangle operation because it's more standard. And I don't know whether you differentiate like different diagnosis to choose different strategies.
Yes, that's also point. If you have a malignant indication, I would always do triangle, and this is also the standard in my department. No matter if it is a urothelial cancer or if it is a pancreatic cancer or a bile duct cancer, we would always have the standard of the triangle operation for these indications. If you have some small neuroendocrine tumor, you probably do not need to do it because then it might be too much because we have no data on this, we have no evidence that then the triangle is an advantage for the patient in the end. So there is some differentiation, but for the classical malignant indications in the pancreatic, we would always do it. Yeah.
And so now I want to introduce the next host, Professor Shania, and we see some documents. So yeah, and Professor Shania.
Distinguished guests from China, the broad specialists in pancreatic disease. Greetings to you all. So we are also joined by the next experts online, like Professor Zakat may have some questions to raise, something you want to discuss. If you do, please. Also, we can reach out to the Chinese experts to see if they have some questions. Also, please share your personal information with profiles. I'll give an introduction to them. It's like Professor Caifeng. Professor Caifeng is from Shanghai Hospital. It's Peking Medical University, so for his roots.
think you already mentioned the important points. I think the laparoscopic procedure, learning a Whipple procedure laparoscopically, takes much longer time than with the robot. And so I personally would advise everybody to use the robot when he starts such a program, not to do it laparoscopically. I know the good studies from China where you have proven that the laparoscopic Whipple is safe and everything, but this is, of course, after a long learning curve with a high caseload. And you all know the experience from the Dutch study group. They tried to do this with a laparoscopic approach and they stopped their study because they had more complications, actually also more severe complications, which underlines exactly what you have said. Laparoscopically is more difficult to learn than robotically.
So I see. So you in Europe, the robotic PD is the laparoscopic PD is not popular, or you think we may perform the robotic surgery rather than the laparoscopic surgery?
Yes, I think so. And in Germany, there are nearly no centers who do laparoscopic Whipple procedures. The ones who do it minimally invasive all do it with a robot.
I see. Thank you very much. 韩亮，你继续，韩亮。
So next, we'll have a Professor Jin Kai Zhou, who is from Fudan University, affiliated tumor hospital. Now, thank you for the invitation of Professor Wang. I am from the tumor hospital affiliated with Fudan University. I have one suggestion and one question goes to Hackert. I want to thank for the discovery of the triangle operation. Triangle operation actually has greatly enhanced our understanding and treatment for the DPA. Well, for the surgery, in my experience, for a triangle operation, it greatly enhances the safety, especially for the arterial blood vessels. One question goes to Hackert. Well, from China's perspective, for the major center of a pancreatic treatment center, as a young physician or for surgeon, how do we overcome the learning curve? I mean, for young physicians, they need to learn, accumulated about a lot of the cases. For example, LPD, like 180 cases. Well, how do we reduce the learning curve for something like a triangle operation? I'm not sure how the young surgeon in your country, how they are overcoming the learning curve.
Yes, of course, they also have the long learning curve for this operation, and I think this is something that can only be done with a good assistant, with a good mentor who is on the table, if you do it open, or who is, of course, assisting you laparoscopically. With the robot, I think it is important that you have a dual console system where you can use two consoles for two surgeons, and you can change the roles without changing to the table or from the table. And then you can do the education and you can do the training. And as I already mentioned, I think you have in China a very good situation because you have incredible caseloads. So you have the opportunity to train many surgeons within quite a short time. And this is just how you should do it from my point of view. And you can, of course, use the simulation and all of these things before. But the first case in your patient, you need some experienced surgeon by your side who is there and who helps you. That's no question.
Thank you for the question. Next, we have the West China Hospital, Mr. Ke. Thank you for the introduction. I just listened to the report of sacred, and so quite wonderful operation and surgery. I have two questions. One is about the pancreatic tumor for the lymph node dissection or ectomy. We have a 360-degree ectomy and also have the triangle dissection. But I saw some of the studies in Japan and other academicians. I learned that the lymph node 9, or compared with the head of the position of the head of the pancreas, the metastatic will be very different. Well, if it's at the neck of the pancreas, it has a higher metastatic rate when it is the tumor is in the neck of the pancreas. So my question is, well, what is your view about the lymph node differences for the treatment? And also we have the metastatic to the distal, for example, the duodenum and other organs involvement, and like duodenum, bile duct, etc. So just to check on your view on this aspect.
Yes, regarding the lymph nodes, I think that the important ones, that was what I showed you in the presentation, and especially for the lymph node number 9, there was no difference. But of course, if you have a neck cancer, you might have spread to both sides, not only the right side of the vascular axis, but also to the left side of the vascular axis. That's why these cancers often have a worse prognosis, and then you may really take away both sides, 360 degrees, as you mentioned. If you really have a clear pancreatic head cancer, I would not do it on the left side, but only right-sided lymphadenectomy and 180 degrees, and not extend it more. But the other organ involvement, I think, is not crucial. If you have a duodenal involvement, this is not predictive for your prognosis, as long as you have no attached other organs or peritoneum or things like that. As long as it's the duodenum or the bile duct, I think there's no difference in the prognosis. You should not change your procedure with this.
Thank you very much. Thank you for the question. Next, we have a Professor Li Wei, who is a practitioner in the pancreatic tumor treatment. Thank you for the introduction. Very happy to be here, well, which is an international activity. Also, I'm very happy to hear the sharing from Sackert, and also admire your contribution. I have two questions. Well, in your slide, you mentioned the PD surgery, where for the duodenum dissectomy, we have the left posterior entry with an artery first principle. Well, in our hospital, we will start from the left side, starting from the vein. I'm not sure for the duodenum dissectomy, it is always the artery first for the surgery. Another one is for the triangle operation. For that, well, is there a definite lower limit or lower boundary? Is it on the lower end of the SMA? And the position of the tumor, is it related with the triangle operation considerations?
Yes, I think this is important that you mention also the veins. You can do an artery first approach as a routine, as I do it usually, but there are some patients where you need to check the vein first, because from the images you know that the vein might not be reconstructible. And this is something that really limits, of course, your resectability. And this is leading to your second question, which means the lower tumors which go into the mesenteric root. Then, of course, you need to check this first, and then you can do the triangle when you have confirmed that you can resect it, and you can reconstruct the vein, for example. But then the procedure is more or less the same. You go, follow the vessels, and you take away everything on the side that you do the operations. But I agree that there's some patients where you need to check the vein first, because the vein is the limit.
好，非常感谢您，谢谢。
Thank you for your answer. Thank you. Next, we have our young physician, young surgeon, who is Lu Zhitun, Professor Lu.
Okay, thank you very much for your introduction. And hello everyone here, professors and good friends. And it's my great honor to be here. I'd like to first congratulate the Xi'an team for their great success in putting up this great international meetings. I think it's just a very important meeting, and I learned a lot from today's lectures and discussions. And I really look forward to our future collaborations and more meetings and more discussions. And for Professor Hackett, it was really a great lecture as always. And I got one question for you. So what's your attitude towards the robotic periarterial divestment? And what kind of surgical techniques do you recommend for the periarterial divestment with the robotic techniques? So you prefer cold dissection, bipolar, monopolar, or even harmonic? So, and I think this question is also for my great friend, Professor Inoue, who is a really expert in robotic surgery for Japan for pan cancer. So please.
Yes, thank you very much. Of course, this is the next step of your robotic skills or your robotic experience if you want to do a divestment with the robot. I think you can do this with a scissor, do it with a cold scissor, so to say, because this is the most accurate way of dissecting it. But as I said, this is something you should only do when you have some really good robotic experience before. This is not for your first case.
Sure. And do you have any ideas about the learning curve? So probably after the cases of repose, of course, robotic repose, then you can start with your ventures with the arteries.
Yes, I think the least that you should have done is about 60 ripples with the robot, because then you have some idea of where the artery is. You don't feel it, but you then know where the artery and the wall is. But this is the minimum number, I think, before you should start to do things like that.
Okay, thank you. So, yes, okay, please.
Okay, yeah, thank you. Thank you for a very important question. And I agree with Professor Hackett about your careful selection of patient, and we should do it after maybe 20 or 30 cases of robotic repose. And also periarterial divestment, also called labyrinthal dissection. My most preferred way of dissection is cold dissection, but it's for only open surgery, because the robotic system doesn't have a very optimal method or instrument for cold dissection. We use the bipolar manual, and as you know, the Japanese robotic surgeons prefers bipolar dissection. It balances the precise and bloodless dissection, even along the artery. And in usual dissection, we put the energy before we plant each tissues. But for periarterial divestment, we seldom use the energy, just the clump crushing, like liver surgery. It's very useful and work well. So Hopefully, I can share our Japanese technique in the next future meeting. Thank you.
Thank you so much. Yeah, I'm done.
I really appreciate the exchange and interaction between the three professors. And any other question? And next professor, Rick Yuan.
Hello, Professor Inoue. Hello, Professor Inoue.
Hi.
Hi.
Yes,
I hope that
here.
this time I have made a very good, very right pronunciation of your name.
Yeah.
Sorry.
Okay.
Sorry.
Don't worry. You can call me Inoue anyway.
Yeah. And also, some Chinese professors want to listen to your comments on the Professor Jin's and the Professor Kerr's questions about the peanuts and the triangle operation. And because you have done a lot of the robotic pancreatic dissections, and also we want to know about your experience and comments on the triangle operation in the robotic procedures and the peanuts surgical precision strategies. So thank you. Thank you for your sharing.
My pleasure. And in the near future, I will make some presentation in this forum.
Yeah. We are looking forward to your lectures. And then they want to know about your surgical experience about the triangle operation applied in robotic pancreas surgery. So can you say something about it now?
No, okay.
Yeah.
Yes. In our opinion, the most important part in pancreatic dissection is an SMA dissection, as you agree. And in our opinion and policy, the approach, how to approach the SMA is the most important and should be standardized in each centers. But each center can choose their most preferred way. And our policy is a combination of both sides. So in open surgery, as I published in Annals of Surgery, we first approach to the SM from right side, but we connect the dissection to the left side. And we can adjust the dissection levels according to the tumor extent intraoperatively. Of course, we decide our strategy based on preoperative finding, but we can adjust even after we open the abdomen. And in robotic environment, the view angle is from corner. So in our opinion, the left posterior approach, like Professor Chillo's open approach, from SMA left posterior side will be the most open and straightforward view for the posterior side of SMA, which is the most crucial point to dissect the unstable or advanced pancreatic cancers. Of course, in less advanced or cardiac abdomen or less advanced tumors, we can do it from right side. But in our experience, we already make us feel the most comfortable to do it in all the reports, robotic reports from left posterior side, as I published in the JSM PBS this year. It's my comments. Thank you.
Thank you, and also
hopefully I can demonstrate. Anyway.
Thank you. And actually, that nowadays that Professor Harker, Professor Wang and Professor Wu Jin, and we are now leading international marketing RCTs for the invasive versus open for the triangle operation in the pancreas surgery. And I hope you can be interested in it, and maybe we can join together to finish this international marketing RCTs. So, what's your opinion? Do you want to join us? Hello? Hello, Professor Ino. Can you hear me now?
Do you call me?
Yeah.
I'm sorry.
I'm glad to
I'm
this,
sorry. The
International
connection
Medicine
come up not so good.
Yes.
So sometimes I miss your comments. But maybe later we can share with email or something in the detail.
Yeah. Okay. Thank you. So how about Professor Giovanni Martinjani? Giovanni, are you there? Yeah.
When doing robotic assisted surgery, there are different considerations, like the cost consideration for each case. So since we started to learn this, we use more harmonic approach. And during our practices, we found that if we use harmonic or ultrasonic very reasonably, we can prevent damage to the main arteries. It can achieve the same effect as the seizures. And for those who have issues with the arteries, I think it's better to use the scissors. So mostly we use harmonic. I think Professor Hackett, I also have a question for you. Just now, Tylo mentioned the possibility of venous reconstruction, and he mentioned that because of the vein invasion issues, it's impossible to reconstruct for some patients. So my question is for Professor Hackett, what are the standards for the impossible to reconstruct veins? What are standards for non-reconstructible veins at your center?
As I think if you go into the already branches of the SMV, then this is sometimes not reconstructible. You need to have at least, let's say, 6 to 8 millimeters of a diameter that you have a safe anastomosis. And if you cannot achieve this, then we would stop the resection.
So due to the time limit, let's close the first session. Now let's move on to the second item on agenda.